Good afternoon, good evening, everybody. I am Dr. Thaw, Senior Consultant Cardiologist from Mynmar. First of all, I want to say thanks giving me the chance to present in this prestigious event. I'm going to present about the PCI in the CKD patients. Because of a very low volume of the cases, meanwhile, due to the COVID-19 crisis, I don't have ESRD patients, but I choose stage 3, 4 CKD patients because management of the PCI in the CKD patient is almost the same. My first case is 54-year-old gentleman presented with the unstable angina, bronchial class 2A. He has a cardiovascular risk factors of hypertension and the diabetes mellitus. His HbA1c is 7.8%. He has a comorbid condition of the chronic hepatitis B virus infection, and his creatinine is 2.1 milligram per deciliter. Estimated GFR is 36 ml per minute, so CKD stage 3B. Okay, his ECG showed the inversion of 1 AV 5.6 and echo is LVE of 60%, mind concentrated LVH, accepted hypokinesia only. So among the PCI steps, I have a special issue in the planning because of the patient, the CKD stage 3B, and the pharmacological issue. I specifically look for the some medications that I thoroughly review for the treatment chart and specifically looking for the medications which can impair the estimated GFR, especially together with the IV contrast. I'm looking for the metformin, NSAID, etc. And another issue is SSI. We usually choose femoral artery approach in cases of the CKD patient to preserve the radial artery for the future AV fistula formation. But fortunately, my vascular surgeon colleagues from my center allowed me to do the radial artery approach because he preferred to do the at the elbow. So I decided to choose the radial artery approach, my preferred side. And then I had some issues regarding the engagement, determine the target lesion and the wiring also because of a very short left main. I'll continue my presentation. I started the procedure with the right radial artery approach with the Tiger catheter, and then you can see that the very short left main contrasts are directly entering the circumflex and the REOM. I can see properly where's the LED. In the cranial injections, I can see the contrast flow into the LED, but I cannot identify properly the target lesion. In the right coronary system, RCA is non-dominant and there's some tight lesion in the mid-RCA also. When I check the left system properly, left circumflex is dominant, and then the two discrete lesion in the distal circumflex. Up to now, I didn't see properly the where the target lesion is. When I make the aerocranial view, I can see that the proximal LED is normal. After the large first septal and between the first and second septal, I can see the discrete, diffuse, eccentric, 70-80% stenosis. This is a stay frame. So at that time, if I want to see identifying the target lesion properly, I need to do some more injection, but I want to save the contrast because of the CKD status. I decided to change directly to the guiding catheter with the GL 3.5 specifically because of the very short left main. As I expected, because of the very short left main catheter directly engaging the circumflex and the REOM while repeatedly entering the Ronbach cells, but I cannot find properly the LED lesion. So you can see that my guiding catheter is up to the circumflex. I can go into the target lesion. Finally, I can manage my wire pass through the target lesion, target vessel, LED. After this stage, the rest of the procedure is easy and straightforward. I do the pre-dilatation and then put the drug-eluting stent 3 or 29 millimeter to the mid-LED and then do the post-dilatation. Here's the final results. In this case, I use the contrast of the ultra-base 370 dual-molar no-ionic contrast. Although I can usually finish the procedure around 100 to 120 ml of the contrast, in this case, because of a very short left main, I have a lot of difficulty in the engagement, finding the target lesion and the wiring. I had to use a contrast at 200 ml. So pre-PCI creatinine is at 2.1. Unfortunately, 24-hour post-PCI creatinine goes up to the 2.5. The patient is okay. Serum electrolytes are fine. So I continue the medical management. 1 week post PCI creatinine is 2.3 milligram per deciliter. My second case is a bit straightforward compared with the first case. 76-year-old gentleman, he's a general surgeon. He also has the cardiovascular risk factors, hypertension, diabetes mellitus. HbA1c is 7.2%. His comorbid condition is a creatinine is 2.3 milligram per deciliter. Estimated GFR is 29 ml per minute. CKD stage 4. He came to me for the medical checkup. He is asymptomatic. Because of his age and the risk factors, I requested CT calcium score. It turned out to be the LED 817, LCX 96, RCA 155, total 1068, high calcium score. His ECG is no STT changes. EF is 67% and no regional wall motion abnormality, moderate LVH only. Actually, he thought that he cannot undergo any kind of procedure with IV contrast because of his increased creatinine. But I explained to him that because of the high risk factors and very high calcium score, he need to undergo the coronary angiogram proceeds. And we can do it with the precaution. I explained that. Finally, he agreed to undergo the coronary angiogram and proceeds. I also did my procedure with the right radial approach also. You can see that distal left main to the proximal and mid LED has a diffuse lesion. Distal left main to the mid LED has a diffuse eccentric 40% stenosis, calcifying lesion, and there's some degree of the branch vessel disease. But clearly, it don't need the PCI. When I check the right coronary system, RCS diffuse proximal to the end of the mid RCS, the diffuse eccentric titus area has 70-80% stenosis. So I explained to the patient and family, and they agree to undergo the ad hoc PCI to RCA. The rest of the procedure is simple, straightforward. Change the guiding catheter, pass the wire, and do the pre-dilatation. And then I cover the most difficult, most tightest area with the drug-eluting stent 3.5, 29 millimeter. After the stenting, but I'm not happy with the plug proximal to the stent, so I decided to put one more stent to the proximal, overlapping with the distal stent. So here's final results. In this case, I used the contrast of the BCPIC 320, isoosmolar non-ionic contrast. In this case, I can finish the procedure with a 150 ml of contrast. Pre-PCI creatinine is 2.3 milligram per deciliter. 24-hour post-PCI creatinine is 2.18 milligram per deciliter. Patient is okay. I can discharge 2 days after the procedure. I calculated the Mirren score for the both patients to predict the risk of post-PCI CNN. Both patients are low. CNN risk score for the case 1 is 9 only. Case 2 is 12.5. Risk of the post-PCI CNN is 14% for the case 1 and the 26.1% for the case 2. I want to share some take-home messages regarding my 2 cases of the CKD patients. We need to thoroughly review the treatment and discontinue the nephrotoxic medication, especially for the metformin, NSAID, etc. And then I want to point out that the most important point in the management of the PCI in the CKD patient is the hydration. Hydration and the hydration. I usually give the hydration in the form of the normal saline. If I have enough time, I usually give 60 ml per hour for at least 24 hours. If I don't have enough time, 120 ml per hour for 2 hours, and then followed by 60 ml per hour up to the procedure. And then we need to continue 12 to 24 hours after the procedure. And in my practice, I usually give an acetylcysteine intravenously or oral 5 to 7 days. Although I use amount of the contrast in my case at 150 to 200, we need to limit the contrast amount. And if it is possible, we need to use isoosmolar non-ionic contrast. Last but not the least, I want to suggest that nephrologist consultation is paramount in the management of the PCI and the CKD patient. Again, my cases are the simple, a bit straightforward. They don't needed to undergo the hemodialysis. In cases of the ESRD patient, we need to arrange hemodialysis section, if it is possible, immediately after the procedure, or at least we need to arrange the day after the procedure. So I want to stress that nephrologist consultation is paramount in the management of the PCI in the CKD patient. Thanks for your kind attention, please.
Values, etc.
Yes, thanks for your question, sir. In our practice, we usually maintain for every patient at least 2 days. We maintain the patient at the hospital. So I usually check 48 hours after the procedure. If everything's okay, everything's fine, I can send back, and then I usually take care for my patient by myself. If patients are away from my hospital, I'll keep them up to the 3-4 days. If in some patients creatinine is a bit high, more than 3 or something, I will keep them at least 1 week. And then I know that I agree with that because some cases creatinine increase, electrolyte changes maybe up to 5-7 days. So if it is possible, creatinine is increased, I keep the patients up to the 1 week in my hospital.
Okay.
Dr. Miraslo, what is the role of IVUS guided PCI in the setting of CKD to reduce the CIN?
This was the question too.
Yeah, that's what point of discussion, I thought, because IVUS guided imaging would reduce the contrast load, and IVUS guided stent implantation and stent optimization probably would be good enough in simpler lesions, at least, even the complex lesions, both.
Even in simple lesions, I fully agree with you.
I want to make one comment.
There is a very clear trend in interventional cardiology, and I think all younger interventional cardiologists should point out or should know in the future we will go more and more with PCI with only minimal amount
contrast.
Of contrast, because our patients will be sicker, older, and this is what we now really implement in our center in Germany. So even 2 or 3 weeks back, I have done a case with zero contrast, just only IVUS guided PCI. It works fine and zero contrast. So this is something what younger doctors will one day, which will be more or less maybe standard in all the patients with kidney disease.
So Murthy, yeah, you had a comment.
Yeah, usually after 24 hours, creatinine goes up. The ideal time to check creatinine is 48 hours.
Yes.
Correct.
Yeah. Point well taken. Yeah.
The amount of contrast generally, or the volume, is equal to the GFR value. So I think we need to understand that and keep it around that figure and not escalate the volume to remarkably high values, because not every patient would respond the same way as Dr. Thaw has shown these 2 cases. Most of them would have a deterioration with 100 ml, 200 ml of contrast.
Yeah, but I fully agree with Dr. Thaw. The hydration is extremely important. So we do this also in our center as a standard.